Hello, everyone. Happy evening. A very good evening. I hope and I believe all of you are doing well. A quick note whether the audio visual is all good. Okay, that's great. Thank you so much, Dr. Shubhu. So, here we are to discuss the short radiology questions for the upcoming FMG exam, which has been postponed to 20th of January rather than the 4th of December. And I'm sorry, Ruxar, for not being able to share the PDF before the class. I'll do that after the class. Okay, I'll do that after the class. Okay. So we are going to discuss images which are like most expected in your exam, and I strongly feel and hope you will definitely get questions from the images that we would be discussing today in your upcoming FMG exam. So make sure you revise this before your exam, like one day before the exam. Also, you revisit all these images, right? And some announcements here. We are launching the NEET PG 2023 Achievers Batch, which is basically a 4 month course, which is starting 21st of November. And the FMD students can also join this batch because the module 1, which is going to start from November 21, that will go on till mid-January. That's approximately till your FMG exam. All the 19 subjects would be revised with the theory and the MCQs. It's going to be like a very, very important course for your revision. And we have significantly reduced the price for the 4 month subscription. It's now at 12.2K rather than 15.3, and you can get 10% off by using the code Dr. Nikita as well. So make sure you make the best of it. So in Achievers Batch, like I was mentioning, the module 1, the rapid revision is till mid-January. So till your FMG, that would be covered. Then the NEET PG students can have IBQs and PYQs as well. Apart from that, there would be a lot of tests as well, which would be happening on the platform, right? And a quick reminder about the MedMinds Ultra Combat 2.0, which has very, very, amazing prizes like the MacBook, iPad, mobiles, Kindle, smartwatch, and stethoscopes. Plus, we get Amazon vouchers and you get significant scholarships. So mark the date, it's November 27, 12 noon. It's a 1 hour test, and while enrolling, you can use the code Dr. Nikita again. And we are also launching MBBS Prof 2 packages, which is available on Android so far. So it will have the recorded sessions, and there would be a live batch as well, which is which has started today, November 15th. And it will also have the mnemonics that I've covered for the respective subjects. So if you have your younger siblings who are in second year MBBS, you can tell them about this. All right, so let's start the discussion of the most important images, the most expected images, right? And you would also see the images that appeared in INICT exam from the images that we are discussing. Okay? So the first one, what do you think is the diagnosis here? So what are we seeing? First of all, this is a CT scan. White bones tells you this is CT scan. This is a non-contrast CT because I don't see the white vessels in the sulcal spaces containing the contrast. So this is a non-contrast CT of the brain. And on non-contrast CT, tell me what is white? That is hyperdense on non-contrast CT. What is hyperdense on non-contrast CT? Either it is calcification or it is acute hemorrhage, right? Or it is acute hemorrhage. So what are we seeing here? Like this one particularly, if I see, this is the hyperdense area that I see. There is another contusion as well with the surrounding edema. But focusing on this one, this is basically hyperdense, not as white as bone. So this is acute hemorrhage. Is this right side or left side? This is the right side of the patient. This is the left side of the patient. It's the opposite. Like the patient in front of you, your right is the patient's left. So basically, this is left-sided acute hemorrhage. The shape is biconvex. That's basically idli shape is EDH, right? So this is EDH, extradural hemorrhage. And points to be remembered for EDH, it is due to rupture of middle meningeal artery, which is basically branch of maxillary artery, right? The first part of maxillary artery. And then we have Right. Then we have lucid interval. Remember the ED, lucid is ED. Lucid interval is present in EDH. And remember, it does not cross the sutures. You can see it is limited by the sutures. And that's the reason it is a biconvex shape or it is lentiform shape. Okay. So this is about EDH. Remember, it's MMA, rupture, the middle meningeal artery. Second one, what do you think is the diagnosis here? Right side, left side, acute, chronic, EDH, SDH, SAH. What do you think is this image showing? Right, the pathology is on the left side, our right side, that is the patient's left side. It is not hyperdense, it is hypodense, right? As compared to the brain parenchyma, it is darker. So this is hypodense. Hypodense means it is chronic hemorrhage, not acute, and it is sickle shape, right? Remember sickle shape, SS, sickle shape is SDH. So this is left chronic SDH. Recent INICT exam question. It is due to rupture of cortical bridging veins, right? The SDH is due to rupture of cortical bridging veins. It crosses the sutures, right? It crosses the sutures. So these are the important points that we should know for SDH. Okay, these are the important points that we should know for SDH. This is what was asked in INICT exam as well. It is the bridging veins rupture which leads to SDH, right? Next one, what do you think is this image showing? So again, there's a hyperdensity. Hyperdense means white, and this is acute hemorrhage. Surrounding that, we can see the dark area. That's basically the edema. So this is acute intraparenchymal hemorrhage, right? The intraparenchymal hemorrhage. The most common cause is hypertension, but in this patient, hypertension seems to be a less likely cause because the bleed is not in the area of the gangliocapsular region, that is in the region of basal ganglia. It's rather in the cerebrum, right? It's a lobar hemorrhage, so less likely to be hypertension. But remember that the most common cause is hypertension. The most common site of intraparenchymal hemorrhage is hypertension ki wajah se it's in the putamen. It is the lenticulostriate branches of MCA basically which rupture. So this is acute intraparenchymal hemorrhage. Okay, this is acute intraparenchymal hemorrhage. All right, next one. What do you think is this one? This is subarachnoid hemorrhage. That is hemorrhage bleeding in the subarachnoid space. What does the subarachnoid space contain? It contains CSF. So what do we see in SAH? Basically, the CSF is replaced by blood. Okay, the CSF is replaced by blood. And that is what we are seeing here. This is the fissure, basically the lateral fissure, the sylvian fissure containing the blood, interhemispheric fissure, perimesencephalic cistern, the sylvian fissure. All of them are containing white blood. This is also called as the star of death. Right, this is subarachnoid hemorrhage. If I tell you with what clinical feature the patient would have presented, subarachnoid hemorrhage presents with thunderclap headache. That is the worst headache of life. There was also the question in the recent NEET PG exam that aneurysm rupture leads to which kind of hemorrhage? It leads to subarachnoid hemorrhage. Why? Because basically in the subarachnoid space, we have the blood vessel. So when it ruptures the aneurysm, the blood will go into the subarachnoid space. So aneurysm rupture leads to SAH. But if the question is what is the most common cause of SAH? The most common cause is not aneurysm rupture. The most common cause is trauma. If the question is what is the most common non-traumatic cause of SAH, then it is aneurysm rupture. Anterior circulation rupture is more common than the posterior circulation. Right, at the junction of ACOM and ACA, the rupture is very common. Right, the junction of ACOM and ACA, previously asked question again. And the last NEET PG question also had a question that ऑप्टिक काइज्मा अगर कंप्रेस हो रहा है तो कहाँ का एन्यूरिज्म हो सकता है? बेसिकली इट इज एकॉम एन्यूरिज्म which will be optic chiasma compression. Okay, ACOM, anterior communicating artery aneurysm basically. Okay, so this is subarachnoid hemorrhage. Can you tell me from pharmacology which calcium channel blocker? It's a frequently asked question. Which calcium channel blocker basically is the drug of choice here in subarachnoid hemorrhage? So for all the students who are scared of pharmacology, you can also watch on Unacademy Plus course. I've taken 15 hours entire pharmacology crash course with all the tricks and mnemonics. Right, it helped all the students in INICT as well. It's not nifedipine, rather it is nimodipine. Okay, remember it is nimodipine, which is basically in subarachnoid hemorrhage. Nimodipine is in subarachnoid hemorrhage, not nifedipine. All right. Next one. Very favorite image in all the exams almost. You would see this image. What do you think is this image showing? Right, it is right-sided pneumothorax. So this entire thing that we are seeing here, basically this one black, jet black without any vascular markings, this is pneumothorax. Why this is not hyperinflated lung? What helps me to identify that it's pneumothorax and it's not the lung? So basically pneumothorax is air outside the lung. Outside the lung in the pleural space, we don't have the vessels, the bronchi, right? So there would be no bronchovascular markings. While if you see the air in the lung, basically it will have this vascular markings. So if I zoom in this image and if you see carefully here, compare the right side with the left side, you would see this vascular markings in the lung, the white vascular markings. While in pneumothorax, there are no vascular markings. So that helps me identify pneumothorax. And what is this white thing here? This white thing here that we are seeing here is basically the collapsed lung. So the pneumothorax is compressing the lung, causing pressure on the lung. So that causes the compression of the lung, the collapse of the lung. And the collapsed lung, because the air has gone out, the black air has gone out, so it appears white. So basically this is the collapsed lung. This is the lining of the lung, which is called as the visceral pleural line, right? The visceral pleural line. Curly B lines, Aditya, they are seen in heart failure and they are a marker of interstitial edema. So curly B lines would be seen here as the short horizontal lines like this. And they basically suggest the fluid in the interstitium, that is interstitial edema seen in heart failure. Okay, seen in heart failure. Take the left-sided heart failure rather than the right side, because the left-sided heart failure is what will give the back pressure into the lungs via the pulmonary veins. Okay. And the question we are asked is, what is the immediate management in this patient? Any patient of pneumothorax, basically first is needle puncture in the 5th intercostal space in adults according to the new guidelines. In pediatric population, still it is 2nd intercostal space. What will be the most sensitive investigation? CT, because for air, basically it is CT scan. For air containing pathologies, it's CT scan. What sign do we see on ultrasound? We do E-fast. Another important question. E-fast has been extended to include the thoracic cavity, right? So the sign that we see in pneumothorax is barcode or the stratosphere sign. Okay, it's a barcode or the stratosphere sign that we see. Normal lung shows what sign? Normal lung shows the seashore sign. Okay, normal lung basically shows the seashore sign, while pneumothorax shows barcode or stratosphere sign. Okay? Next one, another image. INICT also had this image, very important. Almost all the exams will have this image, and this is this air under diaphragm, free air under diaphragm. That's basically pneumoperitoneum. Okay, free air under diaphragm, that's basically pneumoperitoneum, right? Most common cause pneumoperitoneum here, perforation, right? The bowel perforation, basically that leads to pneumoperitoneum. And there was question in INICT as well on the management aspect, on the signs in pneumoperitoneum. Management is basically first resuscitate, stabilize the patient, and laparotomy. Emergency laparotomy needs to be done for perforation. Exploratory laparotomy needs to be done. And apart from that, tell me quickly some X-ray signs in pneumoperitoneum. One, Rigler's sign. Remember, it's Rigler's sign. It is not the Rigler's triad. Yes, after X-ray, do a contrast enhanced CT, basically with the oral contrast. Now remember this concept here. In perforation, barium is contraindicated. In perforation, barium is contraindicated because it's water insoluble. It goes out of perforation site, irritates the peritoneum, causes peritonitis. While the iodinated contrast, water soluble, even if it goes out, it gets absorbed. You can do contrast CT. Oral contrast uses iodinated contrast. We need to give oral contrast because when you give the oral contrast, iodine, it will go out from the perforation site. So we will see the iodinated contrast accumulating around the site of perforation. So wherever that iodinated contrast is accumulating, we get to know that that's the site of leak. That's the site of perforation. So we as radiologists help the surgeon in localizing where the perforation is. Right. So we need to do CECT with oral and IV contrast both. Okay, CECT needs to be done with both oral and IV contrast. Okay. So remember, barium is contraindicated. It's a previously asked question. Esophageal perforation, what contrast would you use? One of the option was gastrographin. Please remember that gastrographin is nothing but a iodinated contrast, but it's a high osmolar iodinated contrast. What we prefer these days is iohexol, which is a low osmolar contrast medium. Okay, it's a low osmolar contrast medium. All right, clear with everyone? So we were talking about the X-ray signs in pneumoperitoneum. Wriggler sign, remember it's not the Wriggler's triad, it is Wriggler sign. Then we have the football sign. This is what was asked in the recent INICT exam as well. Football sign, Wriggler sign, all the ligament signs, be it falciform ligament, the Urachus sign, right? And then we have the cupola sign, the air beneath the central part of diaphragm. That's the cupola sign that is seen. And we have the inverted V sign as well, the medial umbilical ligaments ke aspas air. That is the inverted V sign. What will be the most sensitive investigation for pneumoperitoneum? Again, air containing. The most sensitive would be CT. What is the best X-ray view for pneumoperitoneum? It is chest X-ray erect. But suppose if the patient cannot stand erect, then what X-ray view will we do? Pneumoperitoneum, Aman, iohexol or iodinated? Iohexol, as the term says, is a iodinated contrast. So it means the same. Right, under the umbrella of iodinated contrast, we have many contrast media. One of those is iohexol. If the patient cannot stand erect, right, then we would do a decubitus X-ray, lateral decubitus. Which lateral decubitus? Right lateral decubitus or left lateral decubitus? Or it will depend on the side of pneumoperitoneum. Which decubitus? Right, left, or depends on the side of pneumoperitoneum? See, it will not depend on the side because peritoneum is just one cavity. We don't have the right peritoneal cavity and the left peritoneal cavity. So always it's the left lateral decubitus so that the air goes to the right. The liver gives a good contrast to the black air. Also, if there is air in the lesser sac, through the epiploic foramen, it will come to the right side, right? So we will also be able to see this perforation and with the air collection in the lesser sac. So it is left lateral decubitus. Okay, remember it's a left lateral decubitus. And always with decubitus, remember it's a horizontal beam of X-ray. This is a previously asked question. So remember it's gonna be left lateral decubitus with the horizontal beam in pneumoperitoneum. Clear? Let's go to the next one. Okay, let's go to the next one. What do you think is this image showing? Yes, basically this is the double bubble sign. We see the one bubble and the second bubble. Again, a very, very frequently asked question. So basically this is a double bubble sign. Double bubble sign is seen with duodenal atresia. So basically depending on where the obstruction is, we get the number of bubbles. If it is stomach obstructed, pyloric obstruction, single bubble. Stomach के बाद duodenum, duodenal atresia, 2 bubbles. Duodenum के बाद jejunum, jejunal atresia is triple bubble. And then ileal atresia, more than 3 basically means there would be multiple bubbles. It would be similar to small bowel obstruction. So duodenal atresia, double bubble. And also remember, double bubble sign is also seen in annular pancreas. So annular pancreas, basically pancreas like a ring. So it is compressing on the duodenum. So that is basically annular pancreas, like similar to duodenal obstruction. So that gives the double bubble sign. Okay, that gives the double bubble sign. What is the clinical feature in duodenal atresia? Is it a bilious vomiting or non-bilious vomiting? It is bilious vomiting because the obstruction basically is beyond the site of CBD insertion. So remember, it is bilious versus CHPS, which is non-bilious. Very, very important point. Stomach obstruction, non-bilious. Duodenal obstruction, bilious vomiting. Duodenal atresia presents on day 1 itself of life, like the first day after birth. CHPS is approximately like 1 month to 5 weeks after birth. CHPS is non-bilious vomiting approximately 1 month of age. So duodenal atresia, remember, also is associated with Down syndrome. Okay, it is associated with Down syndrome. So that is about double bubble sign, duodenal atresia. Next one, what do you think is this image showing? This has been asked in NEET PG 21 also. And so the congenital heart diseases, X-ray appearances are something which is very, very important. Absolutely right. So basically this is the heart, and above that there is one more shadow that basically is giving what appearance to the heart? The figure of 8 appearance. Okay, that's basically giving the figure of 8 appearance, or it is also called as the snowman heart. Okay, or it is also called as the snowman heart. How do we draw a snowman? Like this, like the figure of 8. So this is, where does the snow fall from? Upar se ya niche se? Of course, snow falls from upar se. Remember, snow is upar se, that is supracardiac TAPVC. Okay, the snowman heart is seen in supracardiac TAPVC, and that's basically type 1 TAPVC. So supracardiac means TAPVC is total anomalous pulmonary venous connection. So all the 4 pulmonary veins do not go into the left atrium where they should go. Rather, they go somewhere else. So they form a vertical vein. It drains like this into the superior vena cava. So it's above the heart. So that is what gives the figure of 8. The heart, and above that, basically the vertical vein forming, the abnormal channel, that gives the figure of 8. Remember, it is supracardiac TAPVC, that is type 1 TAPVC. Okay, look at this image as well. This is again the same thing. This is the heart, and above that the abnormal shadow, that is the figure of 8. Okay, that's the figure of 8 or the snowman heart. Okay, that is supracardiac TAPVC. Next one, asked in the recent INICT exam as well. Of course, this will not be asked in the exam ki boot bana hua hai, image aaya hai. This is what will come in the exam. So basically, the boot shape heart is the heart with the apex gone up. Why does the apex go up? Why do we get the boot shape heart? NEET PG question. Why do we get the boot shape heart in tetralogy of Fallot? Because it is associated with RVH, the right ventricular hypertrophy. When the right ventricular hypertrophy is there, apex goes up. Left ventricular hypertrophy, the apex goes down and out, right? So that is RVH, tetralogy of Fallot. That is a boot shape heart. Okay, that is boot shape heart. And what is the other name for this boot shape heart? The other name for this boot shape heart basically is Cor and Sabo. So remember, Sabo is like boot. So it is also called as Cor and Sabo. Okay, Cor, coronary, Sabo is the boot shape heart. And also remember that in TOF, tetralogy of Fallot, is there pulmonary oligemia or pulmonary plethora? So basically there is pulmonary oligemia, decreased blood supply because of pulmonary stenosis, which is a component of TOF. So remember, there is pulmonary oligemia, not pulmonary plethora in TOF. Okay? and significant number of patients can have right-sided aortic arch in TOF. Okay, it has a right-sided aortic arch associated with tetralogy of Fallot. Okay. Next one, again NICT question. This is favorite with all the examiners somehow, and that basically is the bird beak sign. So the narrowing in the lower part of the esophagus, that is the bird beak sign, the rat tail sign. That's basically achalasia cardia. Okay, achalasia cardia. The question asked here is, what is the gold standard for achalasia cardia? The gold standard investigation is manometry. Remember, it's not 24-hour pH monitoring. Where do we do 24-hour pH monitoring? pH is basically for acid alkali. So basically it is for the acid coming into the esophagus. That's basically GERD. Okay, that's basically GERD. That is 24-hour pH monitoring. Manometry, because we want to measure the pressure in the LES. The problem in achalasia is LES is contracted. What classification do we use for achalasia? Remember, there is Chicago classification. Achalasia basically is Chicago classification. Okay, Chicago classification. Haller's myotomy or even Poem surgery is done for achalasia. Okay, so remember, this is achalasia cardia. The LES contracted gives the bird beak. The proximal esophagus is entirely dilated. How do you differentiate it from malignancy clinically? In achalasia, what is dysphagia more to? Dysphagia is more to liquids or to solids in achalasia? In achalasia, the dysphagia is more to liquids or to solids? Dysphagia more to liquids. That is what the history would be given. Why? Because the solid आएगा कुछ, the solid with the increased pressure will overcome the pressure of LES. So that is why solid से ज़्यादा problem नहीं है, but liquid से ज़्यादा problem है. In malignancy, it's a fixed narrowing. In the esophageal lumen, it's a fixed narrowing. So liquids also, solids also, there would be dysphagia to both. Right, there would be dysphagia to both. Okay? So that is about achalasia. Next one, what is this image showing? This is the corkscrew esophagus. Right, this is the corkscrew esophagus that is seen in diffuse esophageal spasm. The patient presents with pain while eating specially spicy food that aggravates the pain. This is corkscrew esophagus, which is seen in diffuse esophageal spasm. Where do you see corkscrew duodenum? This is esophagus. Where do you see corkscrew duodenum? Where do we see the corkscrew appearance of the duodenum? That's basically the twist in the duodenum. That twist is the volvulus. Okay, that is seen in mid-gut volvulus. Okay, that is seen in mid-gut volvulus. The twisted duodenum, corkscrew, that is mid-gut volvulus. Okay, clear with everyone? Going to the next one. Again, recent NICT exam question as well. This is the classical appearance that we are seeing. That is the coffee bean appearance, right? That is the coffee bean appearance of sigmoid volvulus. Okay, that is basically sigmoid volvulus. And what are all these? What are all these, the rest of them? The sigmoid volvulus is causing the back pressure and the proximal large bowel dilatation. So this is sigmoid volvulus basically with colonic dilatation, right? So there is the sigmoid volvulus basically with colonic proximal colon dilatation. This is sigmoid volvulus, right? Sigmoid volvulus, coffee bean appearance, also called as the omega sign, right? It looks like the omega, or the bent inner tube sign, or the bent inner tube sign. Okay, that is called as omega or the bent inner tube sign. The three lines converging like this in the coffee bean, that's basically also called as the Freeman-Dahl sign. Okay, that's the Freeman-Dahl sign. Sigmoid volvulus versus cecal volvulus. Remember that sigmoid volvulus is ahostral. Hostrations are absent in sigmoid volvulus. Okay. Absolutely right, Dhruv. That is On barium enema, the sigmoid volvulus will give that bird of prey or the bird of beak appearance. The barium goes up, stops at the point of volvulus. That gives the bird of prey sign. Some books also call it bird beak sign. That's on barium enema. Okay, that is on barium enema. Where do you get the claw sign on barium enema? Claw sign, very, very important. It is seen in intersusception. The barium goes up, and then it spreads like a claw. Okay, that's the claw sign. It also gives the coiled spring sign, the investigation of choice ultrasound. It gives the target sign or the donut sign, inner circle and an outer circle. Okay, that is intersusception. Classical history would be red currant jelly stools. Okay, red currant jelly stools is the classical history in intersusception. Okay. Next one. What is this image showing? What is this image showing here? This is barium enema. And what are we seeing on barium enema? Diverticulosis. Okay, diverticulosis. All these are the outpouchings of barium that we are seeing, the outpouchings of barium. So this is basically colonic diverticulosis. Diverticulitis is with inflammation. And what appearance is this called as? This is called as sawtooth appearance. Okay, so basically the diverticuli, the outpouchings give this sawtooth appearance. So that is the sawtooth appearance diverticulosis. Investigation of choice, barium. But if the question is, what is the investigation of choice for diverticulitis? How will a patient of diverticulitis present? It's gonna be pain in which quadrant of the abdomen? Right upper quadrant, left upper quadrant, right lower quadrant, or the left lower quadrant? Diverticulitis will present as pain in which quadrant of the abdomen? That is left lower quadrant. Why? Because the most common site of diverticuli is sigmoid colon, which is present in the left lower quadrant. Sigmoid present in the left lower quadrant. The high pressure leads to diverticuli. So pain in left lower quadrant, think of diverticulitis. The investigation of choice would be CECT, right? Contrast enhanced CT. What classification do we use? What grading do we use for diverticulitis? It is Hinchey's classification, basically to see where all the pus has spread. Okay, that is Hinchey's classification. Okay, diverticulitis. And that's the sawtooth appearance in diverticulosis. All right, so that was about the today's quick session on the most important images in radiology. Let us quickly revise this, what all we have learned. So EDH, biconvex, SDH, concavo-convex or sickle shape. Then we have intraparenchymal hemorrhage. Then we have subarachnoid hemorrhage. Then there is pneumothorax, black without any vascular markings. Air under diaphragm, pneumoperitoneum. Remember, it's left lateral decubitus with the horizontal beam. Double bubble, duodenal atresia, annular pancreas. Figure of 8, that is TAPVC, supracardiac type. And boot-shaped heart, tetralogy of Fallot. Remember, there is pulmonary oligemia. RVH gives the boot-shaped heart. And this is the bird beak sign, achalasia, dysphagia, more to liquids. Manometry is the gold standard. Then we have the corkscrew esophagus, that is diffuse esophageal spasm. Coffee bean sign, sigmoid volvulus. And then you have the sawtooth appearance, basically which is seen with diverticulosis. Okay, sawtooth appearance with diverticulosis. All right. Thank you so much everyone for joining in. I hope this session helps you and you see a lot of images coming from here in the upcoming session. And do not forget, intersusception also is a very potential question for your exam. So goodbye everyone, take care and keep studying, keep revising and keep winning. Soon I would be coming up with a new timetable for the FMG students and the NEET PG students as well. Thank you, goodbye, take care.